Hi, everybody, and welcome to Arthritis Talks, Alternatives to Joint Replacement Surgery. My name is Sean Brady. I'm the Vice President of the Arthritis Rehabilitation and Education Program, as well as Innovation at Arthritis Society Canada. And we can't thank you enough for joining us for this great topic tonight. Now, while we have come together for this event from many different places across the country, I would like to acknowledge that the land on which I am located stands on the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. And today, this meeting place is home to many First Nations, Inuit, and Métis people, and I'm grateful to have the opportunity to live and work on this land. Now, many people with arthritis believe that total joint replacement surgery is the only option that will relieve their arthritis pain. Regardless of which joints are affected by arthritis, in many instances, joint preservation can be achieved without the unnecessary pain and recovery time that comes with the total joint replacement. So tonight, we are so thrilled and fortunate to be joined by Dr. Femi Ayeni, who will share various non-operative and operative options that don't involve a total joint replacement. Now, before we get started, we do have a few logistics we want to run through. This webinar is best viewed on a laptop or a desktop computer. So if you have technical difficulties during the presentation, you can email arthritistalks@arthritis.ca for assistance. If you have a question of our presenter, you can submit it through the Q&A button at the bottom middle of the screen. We'll try to get to it as we have many questions as possible during the 1 hour that we have together. You can also click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and Arthritis Society Canada's chat moderator. If you would like to close the chat completely, you can click the red X icon to close out that window. Now, we're pleased to continue providing captioning for all of our webinars to accommodate the diverse needs of our audience, and you'll see that running along the bottom of your page. Many questions we received in advance followed similar themes, so we will address those questions, but we also will try to reserve some time to look at some live question and answer questions that come up during the session, and we will do that towards the end. Now, before we get started, I did want to thank our event partners, Pfizer, United Way Winnipeg, and our other partners for their financial support of the Arthritis Talks series. So it's that time. Let's get started. I wanted to give a warm welcome to today's expert, Dr. Femi Ayeni, who is joining us here from Hamilton, Ontario. Welcome, Dr. Ayeni.
Thank you for having me. It's a true honor and privilege to join your organization to talk about a very important topic and something that I've tended to focus a lot of my career on as far as studying it with research and trying to help people in clinics and in surgeries. And so I really think that, it's a hopeful day that we can talk about some of the innovative strategies that may exist and potentially, broaden some of the options people may have who may be, struggling with osteoarthritis.
Fantastic, and it is a highly popular topic, and I think we'll get right out of the gate and ask you a first question here. Could you start tonight's discussion by touching on how osteoarthritis is diagnosed?
Yes, I think that it's very important, but we still go back to the fundamentals and basics when it comes to that. And when I advance the slides, you can see that I am examining somebody in clinic, and I'm also showing you a picture of an X-ray. So, oftentimes when you have symptoms and friends have symptoms of osteoarthritis, it's sort of, one of those tell me how you feel type scenarios, and people assume they may have that condition, but it really is going to see somebody who has experience in diagnosing by asking you questions. When is your pain? Is it activity-based or related? Does it have trends, sometimes with atmospheric changes? Does it have any other limitations? Is it one joint? Is it multiple joints? And importantly, do you have a family history of osteoarthritis? So all these questions are very important, knowing when the pain starts, what triggers it, what relieves it, what is tended to work as far as over-the-counter medications. So a history is very important. That's just asking questions. That will never change in medicine. And then your physical examination is very important, and that's what you see on the examination table. So we usually look, move, and feel. So we look at the joint that's impacted or affected, and then we tend to, as a physician, you would have your physician move that joint and listen for things like crepitus, which is crunching of the joint. How much limitation is there? So if you can move one limb, let's say all the way at 100 degrees, You look at the other limb and ask, okay, does that one go half as much or more or less? So you usually, the beauty of having, multiple joints, and usually two of them, if you look at major joints, is that you can compare side to side. So, Sean, I would say, starting off with understanding the story of the patient, understanding how the joint moves, how it looks, how it feels during testing, and then finally you get on to imaging. And imaging involves X-rays typically, and then ultimately, depending on how bad your X-rays look, may involve an MRI as well.
Fantastic. Thank you for that thorough overview of how osteoarthritis is diagnosed. Our next question is around treating joint pain without surgery. So if you could please discuss and talk us through what non-operative options there are available to treat joint pain.
So another great question. Oftentimes, people would like to avoid surgery, and although they come to see somebody like myself who's a surgeon, in a sense, I'm the last person they'd like to interact with, because, the strategy always is, can I get better without going under the knife, and the downtime involved and that sort of thing. So generally speaking, there are non-surgical options when you have a diagnosis of osteoarthritis, especially if it's in the category of mild to moderate osteoarthritis. So when you look at arthritis, and I know I'm speaking to a very sophisticated audience of people who may have friends and relatives who are impacted, but you can have mild, moderate, and severe. So if you're looking at mild and moderate osteoarthritis that is troublesome and affecting your function, then typically you have the opportunity to pursue some non-operative options. So we'll get into that in the next slide or so. I think, first thing is, when you're looking at these options, and sometimes it is overwhelming for many patients to go in for a 10, 20, or 30-minute visit and have a physician like myself download a lot of information in a short visit. And then you start to try and process it, and you go, wow, this is very, very difficult to try and wrap my head around, because I got a bunch of options, but I don't know which one works best. And so this grid that you see on this screen sort of shows you how we tend to think about the science of managing people and the science of information. So whenever you talk to your doctor, whether it's your family doctor, your surgeon, your rheumatologist, it's important to ask a question, what is the level of evidence that exists for this particular treatment, whether it's an injection, physiotherapy, a surgery. And if your doctor says, wow, we have level 1 evidence, that typically means we have very, very good research and studies. If your doctor or healthcare provider says we have level 5 evidence, that means that we're just still scratching the surface of understanding what's going on. And we have some ideas, but we don't really have perfect science to support it yet. And oftentimes, many interventions, whether they be injections or therapies, or even some surgeries, live in the level 2, 3, and 4, which are somewhere in the middle. So 1 is the best, 2 second best, 3 is third best, and so on and so on. So really, when you are seeing and speaking about that, and you're questioning what your options are, it doesn't hurt to ask what level of evidence exists for what treatment you're offering to me. And that's a very important one. But moving on from there, luckily, in some of my roles in working with the Arthroscopy Association of Canada, we've really looked first at injections because, as you know, Sean, injections tend to be one of the first line treatments. So certainly when you have osteoarthritis, you would start off with activity modification, perhaps some strengthening and therapies to make sure your joints feel stronger and are supported. And, once you've, passed those initial strategies of, physical exercise, physical therapy, maybe over-the-counter medicines, you typically would show up to your doctor if those aren't working. And then we start to discuss the injection space and what is possible and what is scientifically supported. And that goes back to the evidence once more. So in these 2 published papers that you see in the screen, we've had the ability to review the world's literature and all the papers out there to try and figure out what is really effective and what works. And through our publications, we've figured out a few things that'll come up in the next couple of slides. So again, back to the evidence, when we graded a lot of these papers that we reviewed, we saw A, B, and C, where if you have really good evidence, that's a grade A, just like in school. A B is fair, and a C is conflicting. And then we had a subscale for 4, against, or inconclusive. But the bottom line really is we wanted to take all of this information about injections specifically and to inform the public and to inform our patients, figure out what works. So if you look at the next slide, you can see that we have the intervention, the hip OA, which is hip osteoarthritis, and then knee OA, which is knee osteoarthritis. So let's start off with the first type of injection: corticosteroids, cortisone injections, that sort of thing, which many people have heard of. And they have strong evidence that it's effective at reducing pain, improving function for up to 3 months. And if that's for the hip. And if you look at the knee as well, it's short-term moderate pain relief and improvement of function. And it is considered to be a cost-effective option. So that cortisone injection that may be offered can help, but it's short-term. And you have to be judicious at how many you get. So there's controversy as to whether it is, every 6 months, 1 or 2 a year. Are there maximum limits per joint? But corticosteroids are not entirely benign, because if you overuse them, you can get some side effects that are not, pleasant. So it is important once more that if you are using that, recognize that there is good evidence for steroids, but there are limits to how many you can get, and they are short-term as far as their effectiveness. When you go to the next intervention, hyaluronic acid, and there are many different commercial players in this, and that is basically a version of synthetic joint fluid. So if you look at the evidence, instead of it being an A, it's a C for the hip. So it does have some potential to improve pain and function for up to 6 months. And if you look at the knee, for example, you see improved pain relief and restoration of function with those who have moderate or mild to moderate arthritis. The key with the hyaluronic acid, I believe, is that it has the potential to give you more sustained relief compared to one of the shorter acting steroids. So most of the time, it does come with a higher price point, and most insurance providers, if you have insurance, may provide it, but it is more costly than a corticosteroid. And then if you go down that line or down the intervention line, you may hear about platelet-rich plasma. It's not exactly a stem cell, which you may hear about with the athletes using, and certainly being the TICATS physician, we always get players who are requesting interventions like this. But platelet-rich plasma basically involves this. You go to a facility where you have your own blood drawn through an IV, and it gets spun in a centrifuge once it's collected. And what that spinning does in a centrifuge, round and round, is it separates the platelet-rich cells from the rest of the blood. And those platelet cells have growth factors that help with tissue regeneration or tissue healing. And so the strategy is you spin your blood, you separate those healing cells, you take them out and re-inject it into the injured joints. As you can imagine, that comes at a higher price point. Now, the evidence for that is also more limited in both the knee and the hip. It does seem to have the potential to improve function for up to a year if it's mild to moderate, involvement of arthritis. And it certainly seems to restore function, specifically in the knee, that has had more, positive results. And the reason is, like most things with osteoarthritis, it seems that the knee has been studied more extensively than other joints. Now, as you go down again into cellular or bone marrow injections, at this point, it's emerging. It's a moving target. The evidence is insufficient, I would say. And then when it comes to combination therapy, such as mixing and matching different formulations that you see above, there is also insufficient evidence. In the knee, perhaps mixing of a steroid and hyaluronic acid, that synthetic joint fluid, could be helpful, but it really hasn't been shown in any other combinations. So I would say that this slide summarizes that the steroids can be short-term effective. The hyaluronic acid, which is basically a synthetic joint fluid that's created to mimic your own joint fluid, that seems to have more longer-term effectiveness. The platelet-rich plasma, which is the blood draw followed by spinning and separating the healing cells, could be effective, but it's still emerging evidence. And then everything else, combinations and even the stem cells, which are from bone marrow, are still investigational at this point.
Great, thank you. So you've talked through how you're diagnosed with osteoarthritis, all of the non-surgical interventions that could be put into place. How do you determine whether you need joint preservation surgery?
That's an excellent question. I think that our strategy has always been to stratify what degree of osteoarthritis do you have. And we tend to go back to the basics once more: history, physical examination, and then imaging. And so when you get the imaging after you've diagnosed somebody with arthritis, we'd like to know if we can preserve your joint so you can keep your own hip, your own knee, your own shoulder. And that's very promising because nothing that we've invented so far, as far as joint replacement, has replaced the longevity of your own joint. So even though naturally our joints would burn out, so to speak, or at age 50 or 60 start to have some troubles, we still don't have any implants that last 60 years. So your own joint and keeping it as long as possible without impairing your function is a strategy we have. But when we look at how to determine that, we tend to say, okay, you have to have mild, maybe moderate, but not severe osteoarthritis. You should have tried a trial of conservative or non-surgical treatment for at least 3 months, sometimes up to 6, and then a documented decrease in quality of life and impaired function with pain. So if somebody comes in and says, hey, Dr. Ayeni, I'd like to see you because my hip or my knee really hurts. I've tried physio for 3 to 6 months. It hasn't helped. I've tried anti-inflammatory medicines, has not helped. I've tried injections. They help for a short amount of time. I've done 2 or 3 of those, but I'm still impaired. And then we go on to the X-rays to see what's going on. And you can see in those 2 pictures what a severe problem looks like and what a mild problem can look like. In that first picture of the hip, things look pretty symmetrical. You see a ball and socket, that's an X-ray. And then if you see that second picture to the right of that, then, or to your left if you're viewing, you see the hip where the ball and socket are touching. You could see what looks like a bunch of little circles, and those are cysts. You can see that that looks quite painful because you have no joint space, you have the friction, and with over time, when you have friction, you start to see cysts. So we talk about joint preservation when you do not have those types of changes because that's really severe. And at that point, a joint replacement is very, very helpful and very useful. So people who are looking for a joint preservation opinion or option should, especially in the surgical side, should first exhaust non-surgical treatment, ensure that their arthritis is not severe, and it's in a mild, potentially moderate category, and it is not generalized, meaning the arthritis is in 1 or 2 spots in your joint, and it's not in the entirety of the joint.
Thank you so much, Dr. Ayeni. There were some questions about what to do when you're continually in pain. I think you actually proactively answered those in the chat, so that's fantastic.
Right.
I'm just curious what joint preservation surgery looks like, if you could talk us through that.
So joint preservation surgery essentially means our strategy surgically is to keep your own joints and repair the damaged tissues. So, if you have a portion of your hip or your knee or a portion of any other joint that's arthritic, sometimes we try and so-called patch that area so that the rest of your joint keeps functioning and the new area is not as painful. It involves sewing tissues that are detached. And oftentimes it's what we call keyhole surgery or arthroscopic surgery, which is putting in small incisions and trying to get to that joint without making bigger dissections to try and repair, restore function, and reduce pain, obviously long term. And it typically would look like something like this. So this is what it looks like if you're here to have a hip, for example, operative procedure that doesn't involve a bigger surgery. So here you can see an X-ray machine. You can see somebody on a table. You can see the hip is all marked up with a bunch of landmarks that we tend to use. And all those little dots are small holes. And when you get to the next picture, you'll see that we're showing some X-rays in what a case would look like. So this person has had history of physical, they had X-rays. We see the hip is starting to get into some early troubles. It may have a few bone spurs that are concerning. And so we've gone an X-ray that you see there and an MRI. And the strategy really is, if you look at that X-ray, for example, the ball and socket look like, well, the ball may not fit perfectly into the socket. It looks a little bit more like we say pistol barrel appearance in the hip. And that just means that the hip isn't rounded or curved. And these are conditions that can trigger early osteoarthritis in your 30s or even your 40s. So as a result, this patient has had pain, has had no improvement with non-operative treatments, and has had an MRI saying there's some damaged tissues. And so then we started to think about surgery. So this is what it looks like when you put a camera in somebody's hip joint. You could see that my probe is probing the surfaces. I'm looking with that silver device that's a resector of bone spurs. So right there, I'm cleaning up the joint. That's how a ball and socket looks in arthroscopic surgery. So after I've put my camera in and this video is playing, I'm burring down all the spurs with a high-speed burr, like a diamond burr, milling down spurs of bone. So my strategy here is to make sure the ball and socket fit together well and the tissues are sewn together well as well. So you can see the joint now. That's what a ball and socket looks like. That's what anybody's hip on this call looks like if it's not too badly damaged. And then we're going to sew back and repair all the tissue, and we're going to test it by probing it to make sure it's still there. Now, this patient that had some mild osteoarthritis and bone spurs, now we're going to take those bone spurs off using that high-speed burn once more. So this patient is asleep. This takes about an hour, and through 2 to 3 small poke holes, we're able to identify the problem, stitch whatever needs to be stitched, file down some spurs, and home same day. But that's an example of a 90-minute operation that was condensed for these purposes into maybe 90 seconds or less. But the goal really is to get into the joint atraumatically and safely without making big cuts. And when I was, coming up as a medical student, even resident, some of these operations, we'd make a big cut down the front of your leg or down the side of your hip. We'd open up all your tissues like a book. We'd see everything, and then we would fix everything, and then we'd close it up, and then you'd stay in hospital, and then you'd go home, and there'd be a long rehab process. A lot of joint preservation now doesn't always require such extensive dissection and involves keyhole surgery that can potentially get you home 2 to 3 hours after your operation, assuming you're the correct candidate.
Fantastic.
I'm just showing here, Sean, what the correction looks like, but it's just essentially, this is what you were seeing in the X-rays. We're making this, if you go back for one slide, you can see that there's something touching the hip, and that's a camera, and the other little device you see there is that bone mill. And we're trying to make this look like a light bulb and take the spurs off the hip ball. And so when you look here, it's looking more and more with each single picture. The hip is looking, if I can point to it, or if I can highlight that with my mouse, I don't know if it shows up for you, but the hip is looking more and more like a mushroom-shaped hip or like a light bulb. And it's not looking as prominent on the outside part as it once did. So the goal really is to make sure at the end of it, somebody with mild arthritis, not too significant, maybe some beginnings of some more early changes that are concerning, pain, we can minimally invasively get into that hip and correct the issues, repair what needs to be repaired, and hopefully prevent the progression of your osteoarthritis. So if we can hold this arthritis off for 10 years and your function to be reasonable for that decade, I think that's a win personally, but of course, everybody has their own value and preferences. But our goal really is to preserve joints so that they can last longer than anticipated. And this is what it'll look like in final pictures. But again, the pictures don't matter, it's the concept. And I think at this point, I'll turn it over to Sean.
What a fantastic overview. Thank you so much. And we actually have had questions in the chat that delve into the next section that we want to talk about. And it's around these options that you've outlined so clearly. Are they available for joints less commonly affected by arthritis, like the upper extremities, shoulders, elbows, wrists, or even ankles?
Yeah, no, absolutely. And I think that I'll segue with that question to show you what a knee preservation looks like. And then at that point would say, for the most part, yes, you do have these options in individuals who have, shoulder conditions that are, impactful, wrist, for example. And if I just click back here for a quick second to show you what an osteotomy would look like. This is somebody who has the traditional legs that curve in. I have that. I was called bow-legged growing up because the inside part of my knees, because of my alignment, are going to wear out faster than somebody who has straight knees or somebody who potentially has different alignment. When your legs curve in that way, you could see the inside part of your knees may start to touch bone on bone, and you start to get early wear and tear and damage of your cartilage or your meniscus. And in a preservation mindset, realigning your leg so that it's straighter and doesn't rub bone on bone has the potential of, again, preserving your own joint, so you keep your own knee for maybe a decade before you may go down the pathway of requiring an operation such as joint replacement. Now, once more, joint replacements are highly successful and very good operations. But if we can maintain and keep your own joint as long as possible, we all think that is a win. So that being said, this is what an osteotomy looks like, where you essentially make small incisions, you realign the bones, and then you put a small plate to hold the bone straight. So the person who you saw before that had previously this alignment where the inside part of the knee is touching and they're a little bit more curved inwards, now their leg is straighter and they have their own knee, but it's realigned. And the goal there would be to buy, a substantial amount of time. But to get to your question, are there similar options? Yes, in many joints. The concepts are the same, whether it's your elbow, shoulder, bone spurs, mild to moderate osteoarthritis. These are all problematic areas, even in the wrist, early arthritis, when you get the painful crunching and grinding. These options that include injections all the way to preservation surgery exist. And then the challenge, of course, is to really try and get into the office of an expert who can be very helpful.
Fantastic. Thank you for that overview and for sharing all of this information. It's been absolutely incredible. And before we get into the question and answer period, I wondered if you had any final thoughts or recommendations for our many viewers here tonight.
Absolutely. I'm enjoying and I welcome the questions that are coming up, I'm sure. And I wanted to potentially, talk about, the options that we've talked about previously. And you can see that's a wrist injection. And the same keyhole operation when you put a camera and look for different joint injuries in the wrist, even a joint as small as that are possible and potentially helpful, especially if it's early stage osteoarthritis with some damaged tissues. That can be very effective. And I look forward to these questions. And I also think that, we should give a lot of credit to the Arthritis Society of Canada for one of the special studies that we are conducting at McMaster University. And, I'll start off with just giving a small background about this study that was just funded by this organization. And what used to happen when I was a trainee was we would see people, in their 30s and 40s, and they would have significant hip pain and some early cartilage damage and some early arthritis. And oftentimes our answers were, well, you know what, you just need to potentially wait until you're in your 50s or closer to get a joint replacement, because there are no options to repair some of the damage we saw. And when you look at the hip specifically, sometimes, patients with osteoarthritis have these potholes or spurs, or rather divots within their hip joint that are very, very, very painful. And it's analogous to having a cavity, on your molar. And every time you chew, that just sends a sharp pang of pain down your entire leg. And then the whole leg just feels like it's jolted. And then you lose your footing, you lose balance, and that can cause other problems. And so what we tended to do over the years is recognize that, the strategy of just asking somebody to be patient and to live with that pain is not really a fair one. And more importantly, it's very painful. And we could do better in our community to do and look for innovative solutions. So one of the solutions that had came up was looking at potentially triggering the body to heal itself and augmenting that healing process using some specialized tissue membranes. And so we applied for some funding from the Arthritis Society to help us investigate this. And we had 13 centers in Canada in this trial. I think almost every major city in Canada decided to join us. And now we're expanding it into Europe as well, because everybody's seeing patients with tremendous amount of pain who may not quite qualify for a joint replacement yet, but are looking for solutions. And so we're very grateful for that. And this is what the science of it is. In some people who have these potholes in their hip and these divots that are called early arthritis, what we used to do to try and solve the problem was to drill multiple holes into the bone. And that is called a microfracture. And you may hear that in sports medicine with athletes. And what a microfracture is you make these small little holes in the bone, and eventually it'll start to bleed through those holes. And all those bleeding cells will sit on top of that cavity that you see in that picture, and eventually start to form some immature cartilage. Now, the cartilage it forms was never quite as good as what you were born with, but it bought you 2 or 3 years. So we thought to ourselves, well, that certainly is not a great answer to help with pain for 2 or 3 years, but not bad. Is there a next generation of research and cartilage repair that can maybe buy more time? And so we're now looking at using a specialized matrix, which after you drill those small holes, you can see that patch is going over top like a blanket to lie over top of that damaged area. And hopefully that can generate improved healing and more longevity of your own joint, specifically in this case, the hip. So for somebody who is, the ages are 18 to 40, I believe, and we may extend it to 50 one day, because we're just in the early studies, looking at how do we try and fix these problems with innovative cutting edge technologies, and putting these cartilage patches may be the future of repairing joints so that you keep your own joint, you stay active, you have less pain, and eventually, get back to what you're doing prior. So we can't do these types of studies because they're quite expensive without the help of organizations that really push science to help people. So we're very grateful to the Arthritis Society for that. So this is what it looks like. We are now back in the joint, and I'm looking at somebody who has, as you can see, the big flap of tissue that's basically peeling like an onion or a banana. That's somebody who is 35, and the other one who is 20, and their hip is essentially collapsing because all the cartilage is falling apart. And once that cartilage, that flap that you see that's being pushed with a metal probe falls down, then you're essentially looking at raw bone, and that person is bone on bone. And we don't have any good answers for that, but the research that we're conducting to try and patch these, repair these areas, are part of the ways whereby if your arthritis is not completely at the end stage, we hope to be able to help you in the future. And I think the future is bright because we're pushing to keep improving how joints function and how we preserve them. So I think the goal really is, as we look at somebody who may look like this, who likes to play sports, and I'm also in that, era of somebody who likes to play despite being older now, I'd like to not have an X-ray that looks like this, that's bone on bone, because I had a problem that might have been fixable with more advanced treatments. And ultimately, we're trying to avoid this for now. So again, the hip replacement and the knee replacement are fantastic and wonderful operations. Nothing beats them. They have good longevity, and we have great surgeons in Canada. But we challenge ourselves to say, can we preserve our joints and keep them functioning and working with a combination of non-operative strategies and operative strategies that are essentially minimally invasive and helpful and keep us going so that we have our other systems, whether it's our heart, lungs, even mental health, to keep going because we can stay active. So with that, I turn it over to you.
Wow, fantastic. Thank you so much for sharing your expertise with us tonight, and just in terms of explaining it in such clear terms and the visuals. It's really fantastic, Dr. Ayeni. Thank you. And not surprisingly, we have a lot of questions. A lot of questions we did receive prior to the webinar, so we are going to theme those and go through some of those questions. And we also have many questions in the chat, and it looks like we're on good time, so hopefully we can get to as many of these as possible. One of the questions that came in was around end-stage knee arthritis. And does that mean when you're at an end stage of this condition of having knee osteoarthritis, is a total knee replacement at that stage the only option?
Yeah, I would say that it is a good option if it's at the end stage. And end stage typically means bone on bone or, 8, 9, 10 out of 10 type discomfort. But, I would still say that we treat the patient and not the X-ray. So even if you have a report saying it's end-stage osteoarthritis, it's always good to try and see what strengthening the muscles around your knee and your leg may do. And that's in the way of therapy to preserve your range of motion and strength. Because even if you go down the pathway of having a knee replacement, the stronger you are going in for a surgery like that, the better your results will most likely be, right? At least potentially. As well, despite having X-rays that say that you have an end-stage problem, An injection potentially, even if it's, a one-time attempt, may bridge you a certain amount of time, especially, we see people who say, listen, I just have a wedding to go to or an event, and I just want to get through 6 months of this before going down the surgical pathway. And I say, okay, well, maybe an attempt, that's non-surgical, non-invasive could be helpful. But I would say that certainly is the gold standard, a replacement for end stage if you failed everything. But also it's important to know if you have end stage arthritis in your knee in one location and the entire knee, because there may be partial replacements that are available from your surgeon if it's just in one part of your knee. So if it's end stage in the medial part, you may have a partial replacement or the osteotomy is stalled. But if it's more generalized, meaning it's in the entire knee, front, back, side, inside, outside, then generally speaking, a replacement is a good option. But ask those questions.
Great, fantastic. And that's a great point to ask the questions of our providers and our clinicians. One of the questions that came in was around exercise. So are there exercise programs that you recommend for people with hip and knee osteoarthritis?
Yes, I mean, I think that general cardiovascular conditioning that's low impact is just a functional basic principles of what works. However, I increasingly subscribe to a lot of these we have to individualize. So, just to say generic stuff is okay, but really somebody like a physiotherapy provider, a kinesiologist, or a trainer has to look at you and understand what else is going on. Because is your other knee affected? Is your hip and knee affected? Have you had any other medical conditions where you can't do certain things? But when you talk about generalized exercise that's helpful, you'd like to have something that gets your heart rate up to a safe level. You want to make sure that you're doing something that is not impact if you have some osteoarthritis, because the higher the impact, the higher likelihood that you will have and trigger symptoms. And you want to make sure it's something that you enjoy and you don't find boring. So you want to be active, you want to be enjoying what you're doing, you want it to be low impact, you want it to have good cardiovascular benefit, so that gets your heart rate, up, but not at unsafe levels. And then finally, the principles of it are, you want to make sure that before you start any exercise program, you consult your primary care physician to make sure that, you're pursuing it at a safe level. But, there are many different websites, that would be recommended. But I think for me, I prefer to individualize these types of recommendations. So having somebody see you, spend that time, and get you specifically assessed is probably the best way to go.
Great. And I will point our guests to arthritis.ca in terms of those general exercises. There are some really great resources at arthritis.ca around exercise, diet, and other elements of taking care of arthritis conditions. One question we had that came in was around bone spurs. And you did address, I think, from a surgical point of view, some of the techniques that can be used. Are there non-surgical procedures or non-surgical interventions for bone spurs that you're aware of and that you could share with us?
When it comes to non-operative management of bone spurs, if they're non-surgical, you're looking at, typically unloader bracing. So that's one area that, can have some controversy. But what you're trying to do is with a really, strong and hinged or a brace that has some straps on it, try and push your joint away so it doesn't rub on that spur. So these unloader type braces are commercially available. They may have a robust price point, but luckily, if you have supplementary insurance, they are covered by most providers, from my experience. But those are some of the interventions, to try and unload the areas that are rubbing and brace them. And they've been more successful in the knee, some in the ankle, and lesser in the hip at this point.
Thank you for that overview. One of our registrants was told that surgery on very overweight patients is not possible. Is this true? And what other options that you've discussed today would apply to overweight patients?
I think that's a great question. First of all, the pendulum is shifting with regards to those types of approaches. I don't know the exact weight. I mean, sometimes when a surgeon may mention that, it's because, there's specific tables that you use in surgery or beds where the surgery is conducted. They may have a weight limit. just by what's commercially available. So most surgery tables, when you're asleep on the operating room, there's always a guidance and a threshold of what's safe before the bed may not function safely. But despite that, there is no defined cutoff where I'd say, this is your weight and you can't have surgery. I certainly think that it's worthwhile looking at another opinion, if that is possible, to see if somebody else is more comfortable and has the experience in dealing with somebody who may have, a higher weight than another surgeon is comfortable with. I would also say that we have a working group in the Canadian Orthopaedic Association looking at this specific issue, because many people are impacted by that concept that, I'm sorry, we can't help you with surgery because you're overweight. And I don't think at this point in 2023 that is the best answer. I mean, if you have equipment limitations, certainly that's understandable, but just to disqualify you based on a weight category seems to be a limited approach. And so with that being said, I would recommend another opinion and understand that this is being looked at high levels to try and help people who have significant joint pain and have, concurrent metabolic issues that may lead to substantial weight gain that they may not be able to readily control. And I think the future of medicine is a team-based approach where you may have in your medical journey an endocrinologist, a bariatric surgeon, and an orthopedic surgeon working as a team to see, okay, well, you have a couple of problems. How can we make sure that we can get the metabolic issues addressed? How can we work together to see if potential options such as bariatric surgery may be, an option if it's, somebody who has significant obesity. And then after that, when is the safe timing for moving on with surgery? So I think those are all things and issues that we have to tackle and keep asking those hard questions.
Great insights. Thank you so much. Curious about inflammatory arthritis. We've talked a lot about osteoarthritis. Other types of arthritis, like lupus, are people with these conditions eligible for joint surgery? One of our registrants with lupus has been told that they can't have joint replacement surgery because it's too risky. Could you talk us through some of the inflammatory conditions and indications for surgery or non-surgery?
Yeah, I mean, I think that, inflammatory conditions generally have, compared to those who do not have inflammatory arthropathies, can have a more intensive and involved post-operative course. And this is where having access to a multi-specialty team and a multidisciplinary approach, can be very helpful. I do not think that, simply because you have that condition means you can never have a surgery, whether it's joint preserving or joint replacing, but you do need extra care and you do need specialized perioperative care to make it happen safely so you get the best outcomes. There's also the concern from surgeons about survivorship. And survivorship is defined as, well, if you have this operation, are these devices going to loosen up or re-tear, or are they going to be, need to be redone in a sooner or faster period than somebody who does not? And that's a concern because evidence does show that some of these inflammatory conditions may impact the healing process and also the wear process of these, implants. But that being said, I don't think it's simply having an inflammatory arthropathy that means that you cannot go through, if you're at the end stage, a procedure. I think what it means is that you need a specialized team to look after you. And generally speaking, you may need to consider a specialized center. At that point, people who have that experience profile, people who have the medical specialty expertise to make sure you go through this safely. And that combination of working together usually gets people through it safely. And I've seen many patients with inflammatory conditions affecting joints have great outcomes.
Great, thank you so much. You mentioned in your presentation around our joints and how long they last, even 50 years, and that technology has not yet caught up to joint replacements or those appliances lasting that long. So one of the questions was around, is it possible to get a second replacement surgery of the same joint?
Absolutely. Revision surgery is more complicated, obviously, when you're looking at arthroplasty surgery, but it depends on what the cause of the second replacement is. Did the joint replacement wear out? Was there an infection? Was there something that failed? And our joint replacement surgeons will assess and analyze that at our center and take an approach to say, well, it depends on why it's failed. But generally speaking, second revisions or revision surgeries are possible, but they're more involved, and they generally are not as successful as the index or first one, just as a general concept, because your best outcome is usually your first one. And so the more sustainability we have with the original implant, the better. And that's why, to bridge you from a symptomatic painful joint to a replacement, these preserving type options can get you to hopefully a decade to push it down to the line, so that you don't need that subsequent revision.
Great, thank you. You touched tonight on, and we had a question around, eligibility for joint replacement surgery for individuals who are overweight. You discussed even younger individuals and the options. What about individuals who are farther along in their lives, who are elderly potentially, who have other health conditions? When would joint replacement surgery no longer be an option for those types of individuals?
Well, that would probably be, the concept is shifting. I mean, you as a surgeon will take the best evidence available and present it to the patient. And we talked about the evidence, level 1 to 5, to say, hey, at this age, these are the risks and benefits. And then, you discuss the evidence. So that's one key. Second is the surgeon will discuss his or her expertise, which is that surgeon who you're dealing with may say, well, I've done this in, a certain amount of people, and these are the outcomes, and these are the risks they found in their career. And then finally, the patient's values and preferences are very important too. So, simply because of a certain age, if somebody has significant functional limitations and quality of life impact, that might trump anything else, in the sense of, well, listen, I might be age X, but this is so painful and so debilitating that, something is my preference, understanding the risks, benefits, and the surgeon's experience, that I should go ahead. So there hasn't really been a frank age limit. And I think this is also going to change, because this is the generation, and we're all in it, that are really going to see an explosive growth in people who are in their 60s, 70s, 80s, 90s. And I've read recent reports that we really will have a boom in people who hit age 90 in our generation and in our lives. So I think that the age cutoffs will certainly start to change as far as this concept.
Absolutely. Let's move on to imaging. So you showed some really great images here tonight in your presentation, and there are some questions that came in around imaging. And one was around MRIs versus X-rays. And if you could talk us through a little bit of which is better, in terms of osteoarthritis specifically, what would be the difference between getting an MRI versus an X-ray? Why would you maybe ask for an MRI in an osteoarthritis condition?
Specifically with osteoarthritis, I would say that an X-ray is the number one thing to do, because that can give you 80 to 90% of the information you need. And then the MRI can add a supplementary 10 to 20%. Now, obviously, the MRI gives you a ton of detail, but when you get an X-ray first, it'll let you know the alignment. So are your legs or arms, are they straight? Are they curved? Are they moving inwards or outwards? So it gives you alignment information. It's pretty cheap for the system and quick to get. So you get an answer almost same day or immediately if you go to an X-ray facility. And rarely an X-ray, even though you're looking at arthritis, you'll pick up other things that may be triggering this. It's not uncommon for people to think they have arthritis and tend to identify something like a lesion that they didn't ordinarily expect, right? And so having that same day or next day X-ray would have picked this up, as opposed to waiting potential months to find that it was not the arthritis. So generally speaking, when you have a screening X-ray to look at the joint to make sure the arthritis is not severe, because if it's severe, you probably are going down one type of surgical pathway, and that doesn't require an MRI anymore. But if it is mild specifically, or even moderate, then an MRI could be helpful to see if there's some specific tissues that are repairable through minimally invasive techniques. So I would say that the X-ray is really a win-win proposition. It's fast, it's timely, it's cheap for the system. It helps you get information about your osteoarthritis. It lets you know if you're mild, moderate, severe. And if you're severe, you go down the pathway of meeting a surgeon for joint replacement. If it's mild or even moderate, you may have the consideration for discussing joint preservation options. And at that point, an MRI could be helpful if you're in that mild or moderate category, to see what else is going on.
Okay, that's great, because I think you've answered another question, which was around when the pain that an individual is having doesn't match up to the X-ray. Then I think what you're sharing is that maybe other diagnostic tools like an MRI could be useful.
Absolutely.
We are in Canada, so we like to talk about the weather. So there's questions about the weather, and just wondering if you could talk us through what weather has to do with arthritis pain, in particular osteoarthritis.
That has been studied, over and over again, people have had conflicting reports as to whether or not the weather, and I've just read a few papers on that to look at the real evidence. So I think it's still being understood. I think more than the weather, whether it's cold or hot, is the atmospheric changes and the barometric pressure changes that can, seem to impact, certain tissues in our bodies, right? Just like when you go up in the airplane and you're up at 30,000 feet and your ears start to pop and whatnot, you may have that sort of sensation in your joints if the atmospheric pressure changes, different altitudes. But that certainly is a work in progress and a science that is certainly not being completely understood. We do know that some people anecdotally would say, I can tell when it's about to rain, when the atmospheric pressure changes. So it's more the change in pressures that can sometimes trigger joint symptoms. But whether it's hot or cold or vice versa, triggering your symptoms, I don't think has been really delineated very clearly yet. But the atmospheric changes as far as the pressure within the air, so to speak, is what is more important at triggering some symptoms.
Great, thank you. Next question is around our health system. And I mean, if we read the papers with the pandemic and with backlogs, it's no surprise that that's on many people's minds. With the surgical backups, one question is around, is Ontario actually doing preventative and arthroscopic surgeries at this point?
Yes, I mean, I would love to say we're all back to working at 100% pre-pandemic capacity, but the reality is we're probably around 75 to 80%. And that's for multiple reasons. I mean, many people have had changes in their practice plans or patterns. We've had a significant unspoken healthcare burnout, not just of doctors, nurses. Many people who had to live through the multiple rounds of caring have really become very tired and need some time off. Also, we still have other sort of waves of other illnesses coming through that are taking resources away. So Ontario is back as far as orthopedic work and imaging and whatnot, but we're still trying to get to that level of what we were pre-pandemic. And then the question is, can we accelerate and get to numbers ahead of the pandemic? So can we get to 120% in these operations? So that's the thing. We need people to do that. We need equipment, we need nursing, we need a whole bunch of factors to sort of align to make sure that we're very efficient with our resources. I do remain optimistic that Canadians generally, as a group, we're smart, we work together well. We like to sort of work hard and help people. And so I remain very optimistic that we will have a Canadian solution for this in the future.
Great, and I think that one of the questions was actually, I think people are quite intrigued with just your knowledge and enthusiasm, and asked about your excitement for the future of the profession. And I think you've just answered that quite well, actually, and quite eloquently. Some system questions. As we know, navigating the health system can be a challenge. Some questions around orthopedic surgeons versus rheumatologists. If you have knee arthritis, which specialist should you see?
Well, I mean, I would say that if you're looking at a non-surgical option and you're in a mild to moderate category, you could see either, but you probably will have, if your goal is to discuss non-operative options, you may have a pathway to see somebody who's non-surgical a little bit faster. But if you're thinking more of surgical options, whether it's preserving your joint because you have failed non-surgical treatments, or if you're looking at a replacement because it's really severe and it's been diagnosed as severe, then I think a surgeon would be, ideal. Ideally, though, it would be integrated. We'd work together, and you may start off your journey with a rheumatologist or a sports medicine physician, and then eventually, as you start to graduate, go to the surgeon if need be. So I would say that if you're certainly in the realm of you've tried everything and it still has a significant functional loss and significant pain, that you should consider a referral to a surgeon. And if you're before that, or you're not looking for any surgery, and you'd like to manage that, then certainly a rheumatologist may be helpful. I do also think if you have an inflammatory arthropathy that requires medical management, medications that are prescribed and monitored and need to make sure they don't affect all other systems, then a rheumatologist may have that expertise that a surgeon may not have in managing medications and dosing and titrating it so that it's safe for you.
Great, thank you. You went through in great detail the whole joint preservation surgical option. Some questions came in, and as we've shared, you are based in Ontario. Some questions came in around joint preservation specifically in those techniques. And is it available across Canada? And if so, what are waiting lists like, if you can answer that? But first question really is, are these readily available across Canada?
Yes, I would say that, our challenge is the access point, but we do have the personnel in Canada to do these great operations. So every major university center would have one, and it may be a travel for people who are in rural areas, but if you get a referral to one of the university hospitals, there for sure I know an expert or two or three that could be helpful with these joint preservation options. I am not entirely aware of a national wait list, but I do know that because there are many people who suffer with arthritis and have difficulties. I can only imagine that the demand for these surgeries outstrips the personnel available. But that's why I wanted to show that there's some non-surgical options to buy time, so to speak, and then eventually move on to the surgical option as need be. So I think a good strategy would be to consider, if you want to talk about joint preservation, obtaining a referral, and at the same time concurrently get the non-operative intervention started.
Great, thank you. And speaking of surgeries, what are some of the risks of having surgery? And maybe talk us through joint preservation as well as total joint replacement might be a good way to look at it in terms of the risks of each.
Absolutely. I think that there are generalized risks and then there are specific risks. So generalized risks are, risks that you may hear about, heart attack, stroke, anesthetic responses or allergic reactions. So those are just general. With any operation, those things can happen. So those are generally very low and are screened before surgery. And then you have specific risks to each operation. The preservation options tend to be in the realm of 1% of blood clots potentially, 1 in 200 or 300 of a fracture of that nature, of things of that nature. And then of course, really bad sort of nerve or vessel injuries are extremely rare. And you're looking at the numbers in 1 in 3 or 4,000. So really rare stuff. And the joint replacement surgeries are also very excellent and very safe. I would say that generally 1% or slightly less is the infection rate. The DVT or blood clot rate is around that as well, but reducing with all the medical management that is being offered, because you'll be in a blood thinner potentially afterwards. And then, the implants failing, dislocating, et cetera, are also quite rare. So I would say because of the advances in anesthesia and perioperative care and our medical management, you will generally be quoted that 1% of surgically related type complication risks, but really they're often less than that.
Okay, great. Thank you. And I think we have time for one more question before we wrap up. And we do apologize. There's many, many questions that came into us, which really shows, I think, the interest in this topic. It might lend itself to a part 2, Dr. Ayeni, at some point. But in the time being, in the short time we have, questions around hands specifically. And just quickly off the top, any recommendations for hand osteoarthritis that you could suggest for us tonight?
Yeah, listen, I think that osteoarthritis of the hand is also very impactful. You eat with your hands, you play instruments, you open doors, etc. So we use our hands every day, right? So, the small joints can be managed with the same injectables that I mentioned earlier on. And there are specific joint replacements that are available for the wrist, and increasingly, specific, for example, the thumb can, metacarpal joint can be replaced. And so they definitely have options for injections and options for surgeries in the hand, and a hand and wrist surgeon will be an expert to kind of connect with, obtain a consult with, and see where your condition lies in the spectrum of mild, moderate to severe, and then you can taper it from surgery to non-surgery. There are even concepts of early wrist replacements coming up in certain centers. So it is very exciting.
Great. Well, thank you. Well, that's all the time we have for questions, but we'd really like to take this time to thank you so much for sharing all of your tremendous expertise here tonight, Dr. Ayeni. Really, truly, I have a bit of knowledge in this area and I learned a ton, and I can't imagine what our webinar participants learned tonight, so thank you. We would like to take a few moments to get the audience's feedback here today on today's presentation. So for those watching on Zoom, you will see a poll question come up on your screen with answer options. So you can please click the response that reflects your thoughts. The two options are, I feel more knowledgeable and empowered after attending this webinar, and I strongly agree, neutral, disagree, strongly disagree options. So please take a moment to complete that poll. It really helps us inform future webinars. Thank you for taking the time to do that. And we will be sending you an evaluation form as well when we email out the recording and the slides. So if you're unable to access the poll question, you still have an opportunity to provide feedback at that time. So we use the survey feedback really to shape the future of these webinars and really value your input. So thank you. Once again, we want to share our gratitude to Pfizer, United Way Winnipeg, and our other partners for their financial support for tonight's event. And please keep an eye on your email inbox for more information about our next Arthritis Talk which is focused on inflammatory arthritis. This is coming up on Thursday, March 9th, or you can always visit arthritis.ca/arthritis talks to check out all of the recordings, previous recordings of our entire series, including this session tonight, which will be posted. So I really want to give you a very warm thank you. It concludes our Arthritis Talks, Alternatives to Joint Replacement Surgery. On behalf of us all, again, thank you and stay well.